Amidst the coronavirus pandemic, I'm sure you're all maintaining the necessary social distance and keeping safe. This pandemic is now spreading across countries and has infected several individuals. But have you ever wondered why only 2 to 5% of these patients who get infected need intensive care become very serious? Is it because of the virus, or is it because of the abnormal host immune response? There has been a lot of talk on cytokine storm that is causing severe illness in COVID-19. And in the next few minutes, I would want to talk on cytokine storm and its relevance to the current pandemic. The objectives of this brief presentation would be to highlight what is cytokine storm, what's the pathogenesis, and to review available literature and its relevance to the current pandemic of COVID-19. COVID-19, as we know, is a disease caused by coronavirus, which is now called the SARS-CoV-2. Although a lot of people get infected, it is only about 2 to 5% of patients that need intensive care support. Age more than 60 years is considered to be a risk factor for severe disease. Most of these patients who land up with severe disease have respiratory failure, and although there are several hypotheses as to why these patients develop respiratory failure, acute respiratory distress syndrome (ARDS) is considered to be the key factor. It is the cytokine storm or hypercytokinemia-induced lung damage and MODS that causes this kind of presentation. And in the initial reports, children have been, to a larger extent, said to be asymptomatic. In the last 2 to 3 weeks, cases of multisystemic inflammatory syndrome have been reported in children, which are temporarily associated with COVID-19. Majority of these reports have been emerging from UK and now from several other countries. These children are said to have Kawasaki disease-like illness or atypical Kawasaki disease. Some of them present with gastrointestinal illness with diarrhea and severe pain abdomen. Many of them land up in shock and have severe myocarditis. Interestingly, majority of them have a negative COVID-19 PCR, and some of them have a positive serology to COVID-19. And the good thing is, most often these children have been extremely responsive to IVIG and steroids. Coming to the topic, cytokine storm. We all know that when there is a storm out there in the ocean, it can sink many large ships. Such a storm of chemicals in our body, the cytokine storm, can cause havoc and kill patients. To understand the cytokine storm further, we shall first highlight the definition of cytokine storm. Cytokine storm is the aberrant production of soluble mediators like cytokines and the accompanying immunopathology. Various people have defined it in several ways, and excessive or uncontrolled release of inflammatory cytokines in context of infectious and non-infectious diseases and the accompanying immunopathology and the clinical consequences could be considered to be a cytokine storm. What is the genesis of this term? This term cytokine storm was first coined in 1993 when people used to describe graft versus host disease as a cytokine storm, and interleukin-1 was considered to be the key mediator of storm in this setting. However, we now know that cytokine storm can be seen in patients secondary to infections. It could be associated with autoimmune diseases like systemic GIA, macrophage activation syndrome, and Kawasaki disease, and several other diseases including the hemophagocytic lymphohistiocytosis is actually a cytokine storm. It can in fact be iatrogenic, wherein patients who are treated for cancer with CAR T cell therapy can develop a cytokine storm. The key cytokines implicated in cytokine storm are interleukin-1, interleukin-6, TNF-alpha, interferon gamma. Although this is a complex thing, but then to make it simple, if we understand that these are the key cytokines, we will be able to understand the pathogenesis better. Now, I'm sure the most important question when we have today is, why does cytokine storm occur in a few? When there are so many patients who are getting infected, why do only a small number of patients land up in the intensive care unit? Why only a few have cytokine storm? To answer that question, we need to understand the pathogenesis behind cytokine storm. And to explain the same, I would take two models. First, the viral infection, and second, Kawasaki disease as a model. Now, this is a very important picture to understand cytokine storm. One has to understand that cytokine storm has not only been reported in COVID-19 but previously even severe influenza. When patients landed up in ICUs, it was considered to be a cytokine storm mediated ARDS that was noted in patients with severe influenza. Now please note this picture. This picture clearly shows a lung with an alveolus which has been infected with an influenza virus. This virus not only infects the epithelial cells but also infects the macrophages and the dendritic cells. It is these dendritic cells which is then release the cytokines, and they also release chemokines, which are chemoattractants, which in turn bring the leukocytes, the neutrophils and the lymphocytes to the site of the tissue. What happens eventually is this is converted to be a battlefield wherein we are trying to clear our enemy, and here our enemy is our virus, and our leukocytes, our army, is trying to clear the virus. Now, it is important to understand that this battle is being fought very much in our homes. What I am trying to tell is that this battle is going on within the lungs. And if you have a furious battle within your homes, whether you kill your enemy or not, you may end up having havoc in your home with a lot of destruction. The same thing applies to this scenario, wherein a battle is fought within the lung field, and if this battle goes unabated, it would result in a lot of destruction within the lung tissue. There would be a lot of cytokines, leukocytes, which eventually cause tissue injury and inflammatory edema, resulting in ARDS. What we all want is a good outcome. And what is good outcome? A good outcome in a patient is when he has a viral infection, there is cytokine release followed by viral clearance. This is followed by dampening of host immune response and healing, and this is what happens in majority of patients, resulting in a good outcome when we say patient has got better. However, some patients can have poor outcome, and that may be because of a viral infection that results in cytokine release. However, this is not sufficient to control the infection, resulting in viral dissemination, multi-organ dysfunction syndrome and death. This is likely to happen in patients who are immunocompromised. Poor outcome could also be entirely because of a different scenario. You have a viral infection, there is cytokine release. The virus is cleared to a certain extent, maybe not complete, but this is followed by an exaggerated abnormal host immune response. And this exaggerated host immune response results in production of lots of cytokines, which initially cause lung damage, and thereafter these cytokines are released in the circulation, causing cytokine storm syndrome, multi-organ dysfunction syndrome and death. Now you can see that the difference between the good outcome and poor outcome could be just a difference in the host immune response. The virus can be the same, but if the host response is different, you get a poor outcome. And to understand this better, we need to understand what do you mean by the host immune response. Now, this picture depicts how does our body fight infections when we at the point of entry. Now, at the point of entry, the first cells that fight infections are called the innate immune cells, and in this picture I would say this is a dendritic cell, and I have depicted the cell membrane, the cytoplasm and the endosome, and you can see on the cell membrane there are receptors, the TLR, the toll-like receptors. These are the pattern recognition receptors which recognize pathogens when they enter into our tissues for the first time. Such toll-like receptors are also present within the cell on the endosome. Now, each toll-like receptor recognizes a different pathogen. For example, the TLR4 recognizes the lipopolysaccharide of the gram-negative bacteria. But today we are interested in coronavirus, and coronavirus is a single-stranded RNA virus which is being recognized by TLR7 and TLR8. Once this virus has been recognized by TLR7, there would be a binding of this viral RNA to TLR7. This happens within the innate immune cells like the dendritic cells, and this will be followed by a production of type 1 interferons within these cells, which will produce antiviral effects, and the virus would be cleared partly. However, due to the interaction between TLR7 and the virus, there is another pathway that is activated, a very important pathway, that is NF-kappa beta pathway, which in turn results in production of interleukin 1 and interleukin 6, and these are the inflammatory cytokines which then produce inflammation within the tissue and in the system. And we would be very much interested to understand this NF-kappa beta pathway, because if this is what will help us understand the cytokine storm. Now, once these cytokines are produced like IL-1 and IL-6, they then recruit leukocytes to the site of tissue, and here the T cells will fight and clear the virus. So, following an acute viral infection, the first thing that you see is there is an increase in viral load. Type 1 interferons are produced, but they increase abruptly, and then there is a decrease in the quantity of type 1 interferons, and this is followed by a T cell response, and these T cells will clear the virus. The T cell response gets abated, the viral load goes down. This is a normal host immune response. So, if you look at the physiology of the host immune response, you would see that initially there is a pro-inflammatory phase followed by an anti-inflammatory phase. During the pro-inflammatory phase, TNF-alpha and interleukin-1 are the first few cytokines to be produced, followed by interleukin-6, which is another pro-inflammatory cytokine. This is followed by an anti-inflammatory response wherein interleukin-1 receptor antagonist is produced, which will nullify the effect of interleukin-1. A soluble TNF receptor is produced, which will consume the TNF, and interleukin-10 is produced, which is an anti-inflammatory cytokine. This is a normal physiological response, which makes sure that following a pro-inflammatory phase, we get an anti-inflammatory phase and there is no further tissue damage. But in a subset of patients, the pro-inflammatory phase can go in an uncontrolled fashion, causing the cytokine storm. In this picture, you can see this macrophage is being infected, say with the virus, and following which it starts producing the cytokines. Now these cytokines like TNF-alpha and interleukin-1 cause leukocyte recruitment to the site of inflammation, and they also result in vasodilation and vascular leakage. These things will result in pulmonary edema and tissue inflammation. Interleukin-6, which is produced, also reaches systemic circulation, and then it reaches the liver, where it causes the production of acute phase reactants like the CRP. And that is why in patients where you have very high CRPs, we believe this is a interleukin-6 mediated disease. And during this period, you also see that these patients develop fever and hyperalgesia, which is again mediated by interleukin-1, 6 and TNF-alpha. Now, how is the virus finally cleared? In the lung, where you have these infected cells, these infected cells eventually send signals to these T cells, and it is these cytotoxic T cells which kill the infected cell, and to do so they produce, as you can see in this picture, perforin, and these perforin creates pores in the target cell, and thereafter enzymes like granzymes are released and there will be apoptosis of the infected cell. This way the viral infection is taken care of, and this is called the cytolytic pathway. One needs to understand this basics of immunology to understand why does one develop a cytokine storm syndrome. So coming to the basic question, why cytokine storm in a few? Now I have showed you this picture before, and you can see in this picture, following a host immune response, the virus is bound to the TLR7 and the NF-kappa beta pathway is activated and you get production of cytokines. However, in a few individuals, the host immune response may be very different, and this is because of the polymorphisms in the TLR genes. The way TLR, the toll-like receptor, binds to the virus, it results in an aberrant, abnormal activation of the NF-kappa beta pathway, causing excess production of interleukin-1 and interleukin-6, and that is what causes the cytokine storm. And you can clearly see that here the cytokine storm occurred because of the polymorphisms in the TLR genes, and that means it is dependent on the host, an aberrant host immune response because of abnormalities or defects in the TLR genes. Is there a proof? Yes, there is a proof to say that TLR polymorphisms and defects in the TLR signaling pathway can result in severe coronavirus infection. And I'm sure you know that this pandemic that we are facing now is not the first coronavirus pandemic. Previously there have been pandemics in 2002 and then subsequently in 2015, and following which people have done a lot of studies. Most often these studies have been carried out in the mice model, and you can see several of these studies which have shown that TLR pathway defects can result in a cytokine storm syndrome. It is also important to understand that chemokines at the site of lung infection play a very important role, and this last paper clearly shows the role of chemokines in the pathogenesis of acute lung injury. So in a given patient, if there are polymorphisms in the chemokines or the chemokine receptors, it can result in an acute lung injury. And as I discussed, the cytolytic pathway wherein the T cell kills the infected cell, if there are defects in this cytolytic pathway, for example, if there are defects in perforin production, this would result in a situation wherein the body is not able to clear the infection, and as a result of this, the CD8 T cell, which cannot clear the infection, keeps producing cytokines, and there will be excess production of cytokines, resulting in a cytokine storm syndrome. So again, defects in perforin and the cytolytic pathway can result in a cytokine storm syndrome and can be the reason for severe presentation in a subset of patients. In order to describe monogenic inborn errors of immunity that underlie severe forms of COVID-19 in previously healthy individuals, Dr. Jean-Laurent Casanova has started this project by name COVID Human Genetic Effort. And I'm sure through this study, he might discover few of the genetic defects that are responsible for severe COVID-19 illness. Now, having spoken about cytokine storm in detail, the next question is, do patients with COVID-19 have cytokine storm? Is there an evidence? And in the last 3 to 4 months, a lot of good papers have been published in several journals, including the Lancet, to show that these patients do have a cytokine storm. And pro-inflammatory cytokines are significantly elevated in severe cases. Now, I would highlight this paper, which was published in the early phase, I would say, which reports illness from China, wherein they studied the clinical and immunological features of severe and moderate coronavirus disease patients, and they could show that severe cases had significantly elevated interleukin 6 levels compared to moderate cases, again highlighting that cytokine storm may be underplay causing severe illness. So what are manifestations of cytokine storm? Cytokine storm can just look like the toxic shock syndrome that we see in our clinical practice. Patients can present with fever, rash, non-specific symptoms like diarrhea, pain, abdomen. If lung is the predominant target, they present with ARDS. The subset of these patients can have myocarditis, and they can land up in shock, and they have MODS with cardiac, lung and renal involvement. Laboratory markers of cytokine storm could be as follows. These patients can have cytopenia, and lymphopenia has been persistently reported in several cases of severe COVID-19. These patients can have elevated liver enzymes, deranged coagulation with very high D-dimers, remarkably elevated inflammatory markers. I must remind you that CRP is significantly elevated in proportion of these patients who have very severe illness, and this is probably mediated by the interleukin 6. These patients also tend to have very high ferritins. But you would agree that when you see a sick patient with cytopenia, deranged coagulation and high CRP, this picture may just mimic a picture of sepsis, and hence we need parameters that help us differentiate in a given patient whether this is sepsis or an HLH-like presentation or a cytokine storm. So this H-score helps us diagnose HLH in a given patient. H-score consists of temperature, presence or absence of organomegaly, the cytopenias, hypertriglyceridemia, hypofibrinogenemia, the level of ferritins, the level of liver enzymes, and presence of hemophagocytosis and underlying immune suppression. And this has been given a score which actually crosses 300. However, in a given patient, if the score is more than 169, you can diagnose HLH with a sensitivity of 93% and specificity of 86%. So this score may be quite useful in clinical practice to diagnose HLH or a cytokine storm in a given patient. However, this score has not been validated in COVID-19 patients, but then can be of clinical relevance. Management. Now, in the last few months, I'm sure you all are aware, a large number of clinical trials are being conducted to treat severe COVID-19 illness. A variety of medications have been tried, but what is very important to understand that supportive care still remains the most important part of the management, because every new medicine and every new trial that has been conducted does not have definitive evidence to date, whereas supportive care definitely improves outcomes. There is definite role of immunomodulation. There have been studies on IVIG, and we as doctors do use IVIG in a lot of patients with cytokine storm, and maybe COVID-19 cytokine storm does have some response to IVIG, and there have been papers on that. There have been a lot of papers on injection tocilizumab, which is a interleukin 6 receptor blocker, and I would discuss that in detail. Interleukin 1 blockers have also been tried in the West. However, these drugs are not available in India. There has been a discussion on steroids, but I would say this would be controversial, especially high-dose steroids in presence of ARDS may be counterproductive, as that would increase the risk of secondary bacterial infections. Now, coming to tocilizumab. Tocilizumab has been regularly used in pediatric patients with systemic GIA, especially those who are refractory to steroids. And as rheumatologists, we are very confident of using this medication, at least in patients with systemic GIA. And there is a definite role of this medication when you have an IL-6 mediated disease. Cytokine release syndrome following CAR T cell therapy can be treated with tocilizumab, and there is enough evidence for the same. However, when it comes to the role of tocilizumab in patients with COVID-19, there has been a meta-analysis that has been published on interleukin 6 in COVID-19 that consists of 8 published studies, 3 preprints and 5 registered trials. And the results of this study have shown that mean interleukin 6 levels have been 2.9-fold higher in patients with complicated COVID as compared to non-complicated cases. A single non-randomized single-arm study has shown decreased oxygen requirements, resolution of radiographic abnormalities, and clinical improvement in severe COVID-19 patients when tocilizumab was used, and there has been no adverse events or deaths reported with its usage. So it seems promising, but then a word of caution. This article is a preprint and has not been peer reviewed. What does this mean? It reports new medical research that has yet to be evaluated and so should not be used to guide clinical practice. And this is what the authors state. So that is, when we have studies out there, we need to be careful whether we could directly extrapolate these studies to our clinical practice. Now, for pediatricians out there, I'm sure there has been a lot of reports that are coming up in the last 2 weeks about a Kawasaki disease-like illness or KD shock syndrome in children that has been for the first time reported from Britain and now from several other countries. And this is one of the newspaper release that says Britain's National Health Authority issued a worrisome alert about children, COVID-19 and potential complication. London and other regions have seen an apparent rise in the number of children with an inflammatory condition requiring ICU care. In fact, Royal College of Pediatrics and Child Health released a guidance on pediatric multisystem inflammatory syndrome temporally associated with COVID-19. And there have been reports not only from UK but even Australian doctors are on alert after Kawasaki disease in children has been linked to COVID-19. So, what are these children? What is this clinical presentation? This looks like incomplete Kawasaki disease. That means these children come to you with fever, rashes, sometimes redness of eyes, but don't have all manifestations of Kawasaki disease. More than 50% of them have required intensive care. Majority of them come in shock, which could be cardiogenic and vasogenic, a combination of both. Myocarditis has been seen in a significant proportion and coronaries can be dilated. Compared to the classical Kawasaki disease, these patients have been quite older. The good thing is they have been responsive to steroids and IVIG. Now, it is of interest to note that this group of patients that have been reported in children, majority of them, COVID-19 PCR is negative. However, COVID-19 serology has been positive in a few, making us wonder whether this disease is immune mediated and is not directly caused by virus but has been triggered by the virus. There is an immune response, formation of immune complex, and it is probably an immune complex mediated disease. It could be a T-cell mediated disease, and there has been a hypothesis that this could be a double whammy. That means these patients, these children, developed coronavirus which was mild or asymptomatic maybe the last month, and now they have got another trigger, probably a virus which has caused this kind of presentation, and they come to us with a Kawasaki disease like illness. But it is important to note that only about 100 cases have been so far reported from UK, and we are in very much early phase of recognizing this new hyperinflammatory syndrome. Now, when you compare this hyperinflammatory syndrome to classical KD, what are the differences? We all know classical Kawasaki disease presents at a much younger age, between 6 months to 5 years, whereas the hyperinflammatory syndrome that has been reported in the West is predominantly reported in an older age group between 7 to 15. Shock that can be seen in Kawasaki disease is only seen in a small proportion, less than 5%, and we call it the KD shock syndrome. However, more than 50% of these patients with hyperinflammatory syndrome are reported to have shock. Myocarditis is often subclinical in classical KD. However, myocarditis has been quite clinically manifest in these patients with hyperinflammatory syndrome. The trigger is unknown in classical KD, and we have been doing research on this for the last several decades. The hyperinflammatory syndrome, which looks like KD and has been recently reported, it appears that COVID-19 is probably a trigger, because this number of hyperinflammatory syndrome, the surge that has been seen is seen only this month, which is a month after the pandemic started in those countries. The good thing is, just like the classical KD, these patients with hyperinflammatory syndrome also appear to be very much responsive to steroids and a combination of IVIG. So to the clinicians out there, especially to the pediatricians who would be quite concerned as to whether we are going to see such presentation in our community. So what I can state is, we'll have some clinical pathways ready for ourselves. If a child presents to you with fever, rash, conjunctivitis, or some features of Kawasaki disease, if the CRP is very high, please check ferritin, and if the ferritin is normal, repeat it the next day if the child is febrile, and if there is a rising ferritin, get an echocardiography done. If there are any features to suggest Kawasaki disease, this could be an incomplete or a typical KD and will benefit with IVIG. If a child presents to you with fever, rash, conjunctivitis, and has high CRP and rising ferritin, some of these children can land up directly in shock, and this is what we call the KD shock syndrome. These children look like Kawasaki disease or a toxic shock syndrome, and their echocardiography can show significant myocarditis with reduced cardiac output. Again, these patients would benefit with IVIG with the combination of steroids. We all know that KD shock syndrome, when there is myocarditis, addition of steroids upfront to IVIG would be beneficial. And a third category of patients who come to us with fever, GI symptoms, severe pain abdomen which may mimic an acute abdomen, and these patients have very high CRP, high ferritin, and they can actually land up with MODS, multi-organ dysfunction syndrome, and they have cytopenias, and their clinical picture appears as if they have HLH or a toxic shock syndrome. Again, this is one more kind of presentation that has been reported in children related to COVID-19 inflammatory syndrome. Again, these patients benefit with IVIG, and if their blood cultures are sterile, they may get additional benefit with the addition of steroids. So what I can only suggest is that we must all be on lookout for KD-like illness in children and adolescents in the next few months. But friends, a word of caution. Our understanding regarding the pathogenesis of this disease is only evolving. A lot of studies are being published, but then the current evidence is limited. A lot of clinical trials are being performed, and I'm sure we'll have better answers in the days to come. We shall learn and treat is what we all doctors want to do, but sometimes we treat and learn. A good combination of these two philosophies is what is needed in the current situation. I'm sure we shall use our best of our minds and try to help our patients and emerge victorious out of this current situation. Stay safe, take care.